Hello everyone in CardioMind's channel, and today we are having an interesting video that many of you were waiting for it for a long time. We are starting to discuss the primary electrical diseases, which are famously called channelopathies, and because of the long topic we are dividing it into two videos, part 1 and part 2. Today we are having part 1. First of all, I dedicate this video to my dear professor and mentor, Osama Diab, who passed away in 2018, by whom I got many of my knowledge I present to you today in this topic of channelopathies. And if it wasn't for him, this lecture would not come to you in this form, and all the animation and Photoshop that you are going to see today are his own design. In part 1, we are going to discuss long QT syndrome, catecholaminergic polymorphic VT, and short QT syndrome. First of all, let's remind ourselves with the action potential in sodium-dependent cells, including atrial and ventricular muscle fibers. We have phase 0 representing the depolarization caused by the influx of sodium, then the repolarization phase 1, I2 current represented by potassium efflux, followed by the plateau phase in which calcium influx is outbalanced by potassium influx, resulting in a steady potential. Then phase 3, efflux of the potassium through the voltage-gated channels, resulting in the return of the potential to the resting state. Then phase 4, including the inwardly rectifier potassium channels, returning the potassium to the intracellular level, and then the sodium-potassium pump, returning sodium outside and potassium inside. So phase 0 represents the depolarization, while phase 1, 2, 3 represents the repolarization. The extracellular potassium and magnesium have an inhibitory effect on the calcium channels in phase 2 and stimulatory effect on the potassium in phase 3. This explains why hypocalcemia and hypomagnesemia would result in long QT interval. Let's start with one of the most famous channelopathies, which is long QT syndrome. There is a terminology called transhumeral dispersion of repolarization, as the peak of T wave represents the epicardial repolarization, while the end of T wave represents the endocardial repolarization. So the duration interval between the peak and end of T wave represents the TDR, which is the duration from the peak to the end of T wave. And when it is prolonged, it is considered a substrate for re-entry, which is spinning intramyocardially, and this occurs in case of long QT syndrome or acquired long QT interval. And this results in early after depolarization, which is a form of triggered activity which may initiate to reset the point in case of long QT interval due to the prolonged TDR interval. This drags us to an important question: how to calculate the corrected QT interval, because we know that we need to correct the QT interval based on the heart rate, because the QT interval itself is variable based on the changes in heart rate. We have the most famous one, which is the Bazzett's formula, based on the QT interval given in milliseconds and the RR interval given in seconds. We have also Framingham formula, Frederici formula, and Hodges formula. The most common one to be used in clinical practice is the Bazzett's formula, but the Framingham formula and also the Hodges formula have higher accuracy in case of heart rate exceeding 100 or less than 60 beats per minute, so in this case it may be preferred to use the other formulas. The basis of most of the subtypes of long QT syndrome, including type 1, 2, 4, 5, 6, and 7, that it is an inactivating mutation of the potassium channels, meaning loss of function mutation, resulting in slow potassium efflux and so prolonged phase 3 of the action potential. So this in turn results in long QT interval. So it is loss of function mutation of the potassium channel. Whereas the long QT syndrome type 3, it is an activating mutation, meaning gain of function in the sodium channels, resulting in reopening of the sodium channels after closure. So there is prolonged repolarization, resulting also in long QT interval. So here it is a different mechanism in long QT syndrome type 3, gain of function mutation in sodium channel rather than loss of function mutation in potassium channels. So this diagram illustrates the normal sodium-potassium channel function, while in long QT syndrome there is reopening after closure, and so this results in the duration of repolarization prolonged and also the duration of long QT interval. So as we mentioned that this results in early after depolarization, which is a common basis of tachyarrhythmia in case of marked action potential prolongation, low heart rate, hypokalemia, calcemia or magnesemia, and long QT interval, as here they occur during phase 2 or 3 before complete repolarization, easily induced in Purkinje and mid-myocardial cells than in the epicardial and endocardial cell. So the ventricular arrhythmias in case of long QT syndrome are mainly triggered by adrenergic activation. That's why in the treatment we are focusing on sympathetic blockade either by medication or by sympathetic nerve denervation in order to reduce sympathetic stimulation. From this diagram, we learn that the age of incidence of ventricular arrhythmia in case of long QT syndrome and also in CPVT is usually in the first and second decade of life, and the VT here is usually polymorphic as we are speaking about torsade de pointe. The annual rate of sudden cardiac death in patient asymptomatic with untreated long QT syndrome is less than 0.5%, and this percentage rises in symptomatic patient to 5%. We can simply divide long QT syndrome into 3 major groups. The first one is the autosomal dominant syndrome without extracardiac manifestation like the subtypes from 1 to 6, and autosomal dominant syndrome with extracardiac manifestation like Anderson-Tawil syndrome known as long QT syndrome type 7 and Timothy syndrome known as long QT syndrome type 8, and the last group is the autosomal recessive syndrome famously known as Jervell and Lange-Nielsen syndrome, which is characterized by severe QT prolongation and congenital deafness. So far, we have 17 genetic variants identified and associated with long QT syndrome. The undisputed genes are those responsible for type 1, 2, and 3, and there are gene-specific triggers for each subtype of them. For example, exercise is a specific trigger for type 1, especially swimming. Auditory stimuli and emotional stress is a specific trigger for type 2, and unfortunately, sleep is a common trigger for long QT syndrome type 3. A genetic mutation has been identified in 75% of all the cases of long QT syndrome, and only 3 main genes which have been mentioned here have been identified in 90% of the positively genotyped cases. The characteristic ECG in long QT syndrome type 1 is a broad-based T wave, and this represents up to 50% of cases. Long QT syndrome type 2 shows slurred or low amplitude T wave, and this occurs in 30 to 40% of cases. In type 3, there is a long isoelectric segment before T wave, and this is less common than type 1 and type 2. And we can see here the end result of long QT interval, which is polymorphic VT occurring on top of long QT interval. This is what's called torsade de pointe, which can result in sudden cardiac death. You can check this reference here, whose link is mentioned in the description of the video, discussing the interplay between genetic substrate, QT duration, and arrhythmic risk. We can see in this triangle type 1, 2, and 3. We can see that type 1 is the most common one and the least risk of life-threatening arrhythmia of therapy, while it is increasing with type 2 and type 3, and they are less common than type 1. We can see also in this diagram that the 5-year risk of sudden cardiac death increase from long QT syndrome type 1 to type 2, then to type 3. And the same interval of QT has lower risk of sudden cardiac death with 1 than in 2 than in 3. One of the simplest tests to diagnose long QT syndrome is brisk standing test known as Weskin test. As with recumbent position here, the QT interval is not apparently prolonged, but with standing, the RR interval shortens but the QT interval lags behind it, resulting in relative prolongation of QT interval, and it is described in detail in the video of workup of ventricular arrhythmias. And also exercise test with 4 minutes recovery time can show lack of shortening of QT interval, which can diagnose long QT syndrome. And here is the patient developed alternating positive and negative T waves in beat by beat. This is called T wave alternance, which is one of the highest signs of risk of sudden cardiac death in long QT syndrome. This table shows a diagnostic score for long QT syndrome based on the correct QT interval, presence or absence of torsade de pointe, T wave alternance, notched T wave in 3 leads, low heart rate for age, besides the symptoms, family history, and genetic finding. Based on the 2022 guidelines, it is recommended that long QT syndrome is diagnosed when QT interval is more than or equal 480 milliseconds in repeated 12-lead ECG with or without symptoms, or the diagnostic score more than 3, and it is diagnosed in presence of correct QT interval more than or equal 460 milliseconds in patients with arrhythmic syncope in the absence of secondary causes for QT prolongation. So when the patients have typical symptoms of long QT syndrome, the cutoff point is lower to be 460, while in asymptomatic patients it can be higher to 480. In patients with clinically diagnosed long QT syndrome, genetic testing and counseling are recommended in order to avoid genotype-specific trigger for each subtype, to receive genotype-specific treatment as we are going to mention, and to permit identifications of the relatives at risk. And it is recommended that long QT syndrome is diagnosed in the presence of pathogenic mutation regardless the QT duration. For example, in family members who had the identified gene but without prolonged QT because they are at risk of having ventricular arrhythmia, although less frequently than the phenotype positive patients, but still at risk. After you diagnose long QT syndrome, you should perform risk stratification to calculate the arrhythmic risk before initiation of therapy using the 1-2-3 risk calculator, which estimates the baseline 5-year risk of life-threatening arrhythmias based on genotype detected and the duration of corrected QT interval, and we can see the link for this risk calculator in the description of the video. We can see here that the 1-2-3 risk calculator is validated to calculate the 5-year risk for life-threatening arrhythmia, and a 5-year risk threshold more than 5% or equal can lead to ICD implantation in 70% of patients with life-threatening arrhythmia, at the cost of ICD implantation in just 13% of patients without life-threatening arrhythmia. And so the conclusion that this risk can be used to make a decision regarding ICD implantation in long QT syndrome patients. Now let's treat this patient. First of all, avoidance. Avoid QT prolonging medication. Avoid and correct electrolyte abnormalities like hypokalemia, calcemia, or magnesemia, and avoid genotype-specific trigger for arrhythmias like strenuous exercise for long QT syndrome type 1, emotional stress and auditory stimulus for type 2. And remember that affected females, especially with type 2, have an increased risk of arrhythmia during pregnancy and the first year postpartum. The first line of treatment is antiarrhythmics at first, ideally non-selective beta blockers like nadolol or propranolol in those with documented QT interval prolongation to reduce the risk of arrhythmic events, and also in patients with a pathogenic mutation and normal QT interval, as they are still at risk of ventricular arrhythmia less frequently than phenotype positive patients. Mexiletine is a sodium channel blocker belonging to the class 1B antiarrhythmics indicated in long QT syndrome type 3, which represent a gain of function mutation of the sodium channel. So a sodium channel blocker here is beneficial. There are no indications whether it should be administered alone or in combination with beta blocker. Also, some mutations of long QT type 3 may not respond to mexiletine, and so we need to perform an oral testing to verify that the QT interval shortens 40 milliseconds before prescribing it as a chronic treatment. When to think of ICD implantation in long QT syndrome? Of course, in those survivors of sudden cardiac arrest, if they have a 14% risk of recurrence within 5 years, even if they are on beta blockers, and in patients who are still symptomatic while receiving beta blockers and genotype-specific therapies, as those have higher risk of cardiac arrest due to the persistent syncopal events despite medical treatment. We may think of ICD in asymptomatic patients with high risk profile based on the 1-2-3 risk calculator in addition to the genotype specific treatment, as if the 5-year risk is more than or equal 5%, so this patient is at risk of sudden cardiac arrest even if he is still asymptomatic. Sometimes we think of a procedure called left cardiac sympathetic denervation, famously known as sympathectomy, in patients who are symptomatic when ICD is contraindicated or refused by the patient, or the patient is on beta blockers and genotype-specific treatment and still having multiple ICD shocks or syncope due to ventricular arrhythmias. It is performed by a video-assisted thoracoscopic intervention. Either ICD or sympathectomy should be considered in patients with symptomatic long QT syndrome when beta blockers and genotype-specific treatment are not tolerated or contraindicated at the therapeutic dose. But remember that sympathetic denervation is not an alternative to ICD for high-risk patients. Sometimes we may use it as a surrogate, but not a complete substitute. And the big no in long QT syndrome, that routine diagnostic test with epinephrine challenge is not recommended in long QT syndrome due to its modest reproducibility. We depend on the 12-lead surface ECG exercise test with 4-minute recovery time and the brisk standing tests. And invasive EP study is not recommended in long QT syndrome. Anderson-Tawil syndrome, known as long QT type 7, is caused by an inactivating mutation in the inwardly rectifier potassium channels, characterized also by some phenotypic features like clinodactyly, low set ears, micrognathia, and periodic paralysis. Presence of syncope or documented VT in those patients is associated with life-threatening arrhythmia, and in a study they found a 5-year probability of 7.9% of life-threatening ventricular arrhythmia. In Timothy syndrome, known as type 8, it is an activating mutation in the calcium channels of phase 2, known as the plateau phase, characterized by syndactyly, cardiac malformation, autistic spectrum, and dysmorphic features. In patients with suspected Anderson-Tawil, genetic testing is recommended, and it should be diagnosed in patients without structural heart disease who present with at least 2 of the following, like prominent U wave with or without prolongation of the QT interval, which is a characteristic ECG feature in those patients, bidirectional and or polymorphic PVCs or VT, dysmorphic features, periodic paralysis, and genetic testing showing pathogenic loss of function mutation in the inwardly rectifier potassium channels. ICD implantation is recommended in those patients after reported cardiac arrest or hemodynamically not tolerated sustained VT. Beta blockers and or flecainide with or without acetazolamide should be considered in those patients to treat ventricular arrhythmia without history of cardiac arrest or not tolerated sustained VT. If those features are not present, so we are considering an implantable loop recorder for patients with unexplained syncope. And ICD may be considered in those with unexplained syncope or having hemodynamically tolerated sustained VT. This diagram summarizes the management strategy of the long QT syndrome. For example, if a patient had an aborted cardiac arrest, we consider the general recommendation beta blockers or mexiletine for long QT type 3, then this patient needs an ICD. If the patient had syncope prior to medical treatment, so also general recommendation beta blockers or mexiletine, then we ask ourselves if the patient had arrhythmic syncope or not tolerated ventricular arrhythmia under medical therapy. In this case, we consider ICD. If the patient didn't have this, so we ask if the medical therapy is contraindicated or not tolerated. If there is no problem, so just continue the medical treatment and follow up. If the patient has a problem with the medical treatment, so we consider sympathetic denervation or ICD implantation. But if the ICD is contraindicated, refused by the patient, or there are recurrent ICD shocks, we consider sympathetic denervation. If the patient is asymptomatic with or without pathogenic mutation and he has QT prolongation, so consider also general recommendation and medical treatment, then assess the 1-2-3 risk calculator. If there are no high risk feature, just follow up. If there are high-risk features, we may consider ICD. If the patient is asymptomatic with a detected pathogenic mutation and without QT prolongation, so we just consider the general recommendation and beta blockers. Now let's move to the catecholaminergic polymorphic VT, famously known as CPVT. We have two major subtypes of CPVT. The autosomal dominant type, which is an activating mutation increasing the sensitivity of the ryanodine receptor 2 to the calcium influx of the plateau phase, resulting in increased calcium release from the sarcoplasmic reticulum, and the autosomal recessive type, which is an inactivating mutation in the cardiac calsequestrin gene, resulting in decreased calcium resequestration into the sarcoplasmic reticulum. So the net result is that there is an increased intracellular calcium in the late phase of action potential, resulting in delayed after depolarization due to the calcium overload. This increased risk of catecholamine-induced bidirectional VT and polymorphic VT in the absence of structural heart disease or ischemia. So here's the exercise and emotional stress, which shows sympathetic stimulation can result in ventricular arrhythmia. The common age of incidence is in the first and second decade, characterized by polymorphic VT. Here the patients show normal ECG. In some patients they may show sinus bradycardia and U-wave and normal echocardiography, so it is diagnosed by exercise test eliciting bidirectional VT or polymorphic VT, or in patients who cannot exercise, epinephrine or isoproterenol challenge tests. Here, as we can see with exercise ECG, the patient developed bidirectional PVCs during exercise. He is still in sinus rhythm, but this can degenerate into bidirectional VT or polymorphic VT. So CPVT is diagnosed in the presence of structurally normal heart, normal ECG, normal echo, and with exercise or emotion-induced bidirectional or polymorphic VT, and it is recommended that CPVT is diagnosed in those who are carriers of the gene mutation, and so genetic testing and counseling are indicated in any patient with clinical suspicion or clinical diagnosis of CPVT. Also, epinephrine or isoproterenol challenge may be considered for the diagnosis of CPVT if exercise test is not possible, but the gold standard is exercise test. After you diagnose CPVT, you should advise your patient to avoid competitive sport, strenuous exercise, and exposure to stressful environment, as all of these can result in ventricular arrhythmias. Then the first line of treatment, as in long QT syndrome, is also antiarrhythmics like non-selective beta blockers nadolol or propranolol in all patients with clinical diagnosis of CPVT, and also in patients who have the gene but without the phenotype during exercise test. They also should receive beta blockers because they are at risk of experiencing ventricular arrhythmia, although less frequently than phenotype positive patients. There is a difference here in the medical treatment that flecainide should be considered in CPVT who have recurrent syncope, VT, or persistent exertional PVCs, while on the highest tolerated dose of beta blockers. We cannot use flecainide in long QT syndrome, for example, because it is a QT prolonging medication, but we can use it in CPVT. It can be used alone in case of intolerance or contraindication to beta blockers, but usually it is an add-on medication. When to think of ICD in CPVT? It should be combined with beta blockers and flecainide in those after aborted cardiac arrest. Of course, this makes logic. And it should be considered also in patients who have rhythmogenic syncope or documented bidirectional or polymorphic VT, while on the highest tolerated dose of beta blockers and on flecainide, because here the syncopal events are associated with an increased risk of cardiac arrest. It is the same indication like in long QT syndrome. Be cautious to program the ICD with long delay and high rates before defibrillation, because this patient have initial bidirectional VT which responds less effectively to defibrillation than subsequent polymorphic VT and VF, so we should depend more on the ATB, and painful shocks here can trigger further and insistent arrhythmia due to the sympathetic stimulation. So try to minimize defibrillation as much as you can. Left cardiac sympathetic denervation still has a role in CPVT in patients with CPVT when combination of beta blockers and flecainide at therapeutic dose are not effective. not tolerated or contraindicated. But 1/3 of the patients still suffer of recurrence, and so it is not a replacement for ICD, but a complementary therapy in symptomatic patients who still have recurrent ICD therapies in order to reduce the ICD appropriate therapies, but not a substitute. And the big no that programmed electrical stimulation during EP study is not recommended for risk stratification in CPVT, the same as in long QT syndrome. This diagram summarizes the management strategy for CPVT. For example, after reported cardiac arrest, we consider general recommendations, beta blockers, and ICD implantation. Then, if the patient is still having syncope or exertional PVCs or VT, we consider to add flecainide, still having syncope or documented VT despite 2 medical treatments, so we consider left cardiac sympathetic denervation. If the patient is having arrhythmic syncope or bidirectional or polymorphic VT, so also general recommendation, beta blockers, then we consider syncope or exertional PVCs or VT to add flecainide. If the patient is still having syncope or documented VT, we can add ICD due to the persistent risk of sudden cardiac arrest, and we can consider left cardiac sympathetic denervation, but not a complete substitute for ICD. In patients who are asymptomatic with no documented ventricular arrhythmia, but they have the detected pathogenic mutation, we usually have this situation in the family members, so just general recommendation and start beta blockers. The last channelopathy to be discussed today is the opposite of long QT, which is short QT syndrome. Here we have an activating mutation of the potassium channels in phase 3, resulting in rapid potassium efflux and shortened phase 3 with short QT interval beside peak T wave and structurally normal heart. There is a different mechanism in type 4 and 5, which is loss of function mutation in the L calcium channels in the phase 2, resulting also in shortened phase 2 and short QT interval. So the net result is short atrial and ventricular ERP, which can increase the susceptibility to atrial fibrillation, VT, or VF. So despite mentioning in long QT syndrome that the prolonged QT interval and prolonged transmural dispersion of repolarization result in early after depolarization, here's the extreme shortening of refractory period increase the susceptibility to tachyarrhythmias. So as we see here in this ECG example, the patient had short QT interval beside peaked T wave, and if we have an echo for this patient, we can find structurally normal heart as we find in most of the channelopathies. So how we diagnose short QT syndrome? The cutoff point is corrected QT less than or equals 360 milliseconds in patient with pathogenic mutation or family history or survival from VT or VF episode in absence of heart disease. It can also be diagnosed in patients with arrhythmic syncope, and it may be considered in presence of short QT interval and family history of sudden death at age less than 40 years. But the cutoff point is shorter in asymptomatic patient to be 320 milliseconds. And of course, in all patients with diagnosed short QT syndrome by ECG, genetic testing is indicated. So in this diagram, we can see the corrected QT interval in milliseconds. The normal is between 360 to 460. Long QT syndrome is diagnosed if the patient is symptomatic, and the cutoff point here is more than or equal 460, and there is a higher cutoff point if without symptoms to be more than or equal 480. And if the long QT interval exceeds 500 milliseconds, it is considered a very high risk cutoff point for torcept. Short QT syndrome is diagnosed with symptoms if less than or equals 360. Previously, the cutoff point for asymptomatic patient was 340, but now it has been displaced to be 320 in asymptomatic patients. The first line treatment in short QT syndrome to go for ICD in patients with survivors of aborted cardiac arrest or with documented spontaneous sustained VT, and also in patients with arrhythmic syncope. So there is no rule here for medical therapy at first as in long QT and CPVT. Otherwise, the patient should have implantable loop recorder, especially in young patients who don't have the other previously mentioned features. The rule here for antiarrhythmic is just for the quinidine, which is class 1A antiarrhythmic that may be considered in short QT syndrome patients who qualify for ICD, but there is a contraindication or refusing it, or asymptomatic patient but they have a family history of sudden cardiac death, to be monitored, of course, for excessive QT prolongation, as sometimes the opposite may occur. Isoprenaline may be considered in short QT syndrome with electrical storm because here it has an effect to reduce the VT and prolong the QT interval. And remember to avoid QT shortening medication like nicotinidiol, which is famously used in ischemic heart disease patients. And the big no for short QT syndrome, that programmed electrical stimulation in an EP study is not recommended for sudden cardiac risk stratification, the same also as long QT syndrome and CPVT, no role at all for EP study. So we have reached the end of this long video of the channelopathies. So the take-home message is that any survivor of sudden cardiac arrest and he has a diagnosis of primary electrical disease, of course we should go for ICD implantation, but the details of treatment is different according to the detected type. For example, in long QT syndrome, non-selective beta blocker is the first line treatment, mexiletine in patients with long QT syndrome type 3. Then we think of ICD in survivors of sudden cardiac arrest or those with recurrent syncope despite medical treatment, or asymptomatic patient with high risk profile. Cardiac sympathetic denervation can be used in those with contraindication or refusal of ICD, or those experiencing multiple ICD shocks despite medical treatment, and no role for EP study. Those with CPVT, non-selective beta blockers at first, then flecainide can be used as add-on medication, and we think of ICD in those survivors of sudden cardiac arrest or patient with recurrent syncope or documented VT despite beta blockers, and flecainide sympathetic denervation can be used in patients who have non-effective treatment or not tolerated or contraindicated, and also no role for EP study. But for short QT syndrome, ICD is the first line treatment as we mentioned. Then we can go for quinidine if those with contraindication or refusal of ICD, or asymptomatic patient with positive family history, and also no role for EP study. Thank you very much for watching this video, and wait for part 2 of the primary electrical disease, in which we are going to discuss the famous Brugada syndrome, early repolarization, and idiopathic VF.